Welcome to the deep dive. You've shared some really interesting sources with us, focusing on, well, complex medical decisions, specifically in geriatric cancer care.
Yeah, it's definitely an area where, the textbook answer doesn't always fit the actual patient sitting there. You have to balance things carefully.
Exactly. And that's our mission for this deep dive, to really unpack these sources, pull out the key insights on how medical teams manage that balance, standard treatments versus the individual patient's risks, their overall health, and crucially, what they want.
And we're going to tackle this mostly by looking at the core of your source material, which is a discussion built around a real-world case study. An 81-year-old patient, the source calls her Jane Smith.
Okay, great. Let's dive in then.
Yeah.
So the source introduces Jane Smith, 81 years old, diagnosed with ductal carcinoma in situ DCIS in her left breast.
Right. And the source makes sure to highlight a couple of key things about her DCIS. It's high grade and it's triple negative. Now, DCIS is technically non-invasive, but those features, well, the source flags them as potentially indicating a more aggressive biology underneath.
Got it. So even though it's in situ, those details matter for the team's thinking. Now, the source is clear. Despite her age and other health issues we'll get to, the goal for Ms. Smith was curative intent treatment. They were aiming for a cure.
Absolutely. Not just managing it. And that clear goal really framed the choices they had to discuss.
Okay, so the source talks about two main treatment options they went over with her. Option A was cryoablation.
Yeah, the source describes that as less invasive, basically freezing the cancer cells. The big plus, as the source puts it, is lower procedural risk. Kind of the safer path, at least in terms of the immediate procedure.
Safer path, okay. Compared to option B, lumpectomy. The
Yeah.
traditional surgery, right? Removing the lump.
Exactly. And the source calls this the gold standard for definitive local control. So highest chance of clearing that specific area. But it comes with those higher risks of surgery, anesthesia, all that.
So there's the dilemma the source lays out, the apparently safer, less invasive way versus the traditional, more definite way that has bigger upfront risks. And the source really stresses you can't just look at the cancer to make this call.
No, you absolutely have to look at the whole person. Which brings us to the geriatric assessment. The source goes into detail here, and it's critical. What did that assessment show about Jane Smith?
It placed her as prefrail to frail.
Right. And the value in the source is how it breaks that down, listing the specific things contributing to her frailty and her overall risk picture.
It's quite a list when you lay it out. Complex medical history, high blood pressure, she's got insulin-dependent diabetes, stage 3B chronic kidney disease.
Which means functionally, her kidneys are only working at about 37% capacity. That's pretty significant.
Very. And then there's Liquis, a blood thinner.
And that Eliquis is a perfect example the source uses for that high wire act, right? If she has surgery, you've got this major bleeding risk during the operation. But if you stop the Eliquis,
You risk a stroke. Yeah, a tough balancing act.
then the source adds polypharmacy. Basically, she's at a lot of different medications daily. More variables, more potential interactions.
And functionally, what did the source say about her mobility?
That's another big piece. Severe spinal stenosis, painful neuropathy. She uses a walker. Her gait, how she walks, is described as slow and antalgic.
Meaning slow because it hurts.
Exactly. So you can see the worry highlighted in the source that a major surgery could really knock back her mobility, maybe permanently.
Okay, so you put all that together. And the source spells out the risks for the lumpectomy pretty clearly.
Yeah, it's stark. High GH anesthesia risk, high GH bleeding risk, and elevated risk for post-op complications. Things like poor wound healing, infection, maybe kidney injury, and a big one in older folks. Post-operative delirium or confusion.
Wow. Okay, looking just at that list, I mean, it seems almost obvious to say, let's go with the cryoablation. It's too risky.
And that's exactly the point the source makes. If you only focus on those risks, those numbers on paper, you could easily undertreat her cancer. You might steer her away from the best cancer treatment just because of her age and these other issues.
But the source argues that's only half the equation, right?
Precisely, that's the vulnerability side. But then the source pivots to Jane Smith's strengths, and this is really important.
Okay, so what are the strengths the source highlights?
Well, first, her cognition is intact. She's described as alert, oriented, and pleasant. That's huge when you're talking about making complex decisions and getting through recovery.
Makes sense. And her goals, you mentioned they were clear.
Crystal clear. The source actually quotes, "The patient's goal remains curative intent treatment. She has chosen lumpectomy to achieve the highest chance of local control." So her values, her desired outcome, they line up perfectly with the more aggressive option.
So she wasn't ambiguous about wanting the best shot at a cure.
Not at all. And then there's what the source calls a massive asset in geriatric care. Her social support. Her son and daughter were right there with her, really involved, committed to helping.
That feels like it could be a game changer. Having that kind of support system at home, the source implies that really boosts the chances of a good outcome, doesn't it?
Oh, absolutely. Strong social support isn't just, nice to have. Clinically, it can make a huge difference, especially after surgery for older adults. It's a real resource.
So you've got this patient, significant risks, yes, but also clear goals, she can make her own decisions, and she has fantastic family support. How does the source say the team brought all that together?
Well, this is where shared decision-making, according to the source, becomes the absolute key. It wasn't just a quick chat. After really extensive conversations, weighing everything, the cancer details, the procedure risks, her health, her function, her goals, and her support, Ms. Smith and her family elected the surgery.
That word elected really stands out. It means she was driving the decision.
Yes, exactly. The source emphasizes she fully understood the risks, weighed them against the benefits she valued, and made an informed choice. She was the active participant.
Not just being told what to do or pushed into something potentially too risky without understanding.
Right. And when she made that choice, the source explains, the medical team's job changed.
Changed from deciding for her to figuring out how to make her choice happen as safely as possible.
You got it. The source details this in the plan section. It's like a blueprint for tackling every single risk they'd identified.
Okay, give me an example, like that high anesthesia risk. What was the plan?
The source says they recommended mitigating that with a regional block instead of general anesthesia, so numbing the specific area, not putting her fully under, less systemic impact.
And the bleeding risk with the aliquis.
That needed really careful, precise coordination with her cardiologist. The source describes a detailed plan for managing the blood thinner around the surgery time, a very tricky balance.
Okay, what about her diabetes?
Specific plan laid out in the source to adjust her insulin carefully before, during, and after.
And those broader geriatric issues, the frailty, the risk of confusion.
That's where that massive asset her family really came in. The plan, as described in the source, involved leveraging their support for round-the-clock help right after surgery, educating them on spotting delirium early, ways to prevent it, and planning for pain control that used fewer opioids to cut down on confusion and side effects.
So it sounds like they didn't shy away from the high-risk option she chose. Instead, they built this, safety net around it.
Exactly. High risk wasn't a stop sign. It was, as the source suggests, a trigger for incredibly detailed, patient-centered planning.
Okay, so let's wrap this up. What are the big lessons, the main takeaways from this case study, according to the source's conclusion?
The source boils it down to a few really key points. First, a number, whether it's age or kidney function or BMI, that's never the whole story. You need that deep dive, that holistic view. Strengths, support, goals, the works.
Right, look at the whole person. What else?
Second, labeling someone high risk shouldn't mean no treatment. It should mean plan meticulously. It's a roadmap, not a dead end.
Okay, makes sense.
Third, and this really came through, the source champions shared decision-making. It uses great analogy. The patient, the Smith, she was the pilot. It was her flight, her choice based on her values. The medical team and the family, they were the essential flight crew, using their expertise and support to help her navigate the journey she chose.
I like that. The pilot and the flight crew, it really shifts the perspective.
It does. And finally, the source basically concludes this case is a perfect example of the art of medicine. Finding the treatment that works for the cancer, yes, but also fits the patient's life, their priorities, their ability to actually get through it and live well afterwards.
That's a really powerful takeaway. Navigating these complex choices, especially with older adults who often have multiple health issues, it really forces you to look beyond the charts and scans. It demands that deep dive into the individual, balancing the hard data with the person's own goals and the support they have around them.
That balancing act, yeah, that's where truly patient-centered care happens.
It really is. So based on this case we've just unpacked, here's something for you, the listener, to think about. How much weight do you think a patient's personal goals and maybe their family support system, how much should that weigh against the cold, hard, clinical risk factors when everyone's trying to make these incredibly tough healthcare decisions? Definitely something worth considering.